संध्याकाळी करू शकतो. ओके दिवसामध्ये तरी चक्कर येते. Helga, you can start sharing your screen so long. Helga, I think Prof. Sheikh might be busy in theater. I think he will join as soon as possible. I think we can start our meeting so long. I don't think he will mind. So good afternoon, everybody, and welcome. Today, Dr. Helga Nauhaus, our registrar, is going to talk about common research language. Dr. Yashoda Manikchand, our consultant, has guided her to prepare the talk. And we are expecting Professor Samaj Sheikh, President of the College of Pediatric Surgeons, to join us as an invited guest. So Helga, you can start your talk so now. Thank you.
Good afternoon, everyone. My talk, as you can see, is on common research language. Over the time that I've tried to prepare this talk, I realized that it's a giant talk, and I've tried to keep it quite summarized. There are a few aspects that I haven't covered in this talk, but yeah, let me show you what we will cover and talk through some aspects of common research language that we come across when we read articles or prepare our MAs. So first, we get a whole bunch of different types of studies. There's observational studies, which are, well, observational. We just see what happens. I'll go through in detail those 4 that are listed there. Then we have experimental studies that always involves intervention. For us, they're usually clinical trials, and they're usually action and control groups, but we'll also go through a bit more detail in those. Then we have meta-analysis and then systematic reviews, and I will go through each one a little bit more in detail. Observational studies, as you can see, has basic 4 groups. They all don't involve any intervention at all. It's just a purely observation of what is actually happening. In case series, we just report on whatever cases or maybe even multiple cases that we've seen. Sometimes audits fall into the same category, but a little bit bigger, where we actually just check what are we doing at this point in time. And they're often the start of research. So the very first point to see what is the status quo and where are areas that we struggle with that we need improvement on, then do an intervention and then follow up on that. Case controls of also retrospective reviews usually involve 2 groups, and we compare those 2, but it's retrospective. There can be bias in those groups. And yeah, not is the next step of trying to see where we are. Then cross-sectional studies are different. We usually come across them as surveys, where from all sorts of areas get sent a survey. Please fill this out. How do you rate this or that on a scale of 1 to 5 or 1 to 10, whichever one they send us? It's a snapshot of what is happening in time, but a single snapshot doesn't compare anything over time. And then cohorts are a group or sometimes groups that share a common trait that's followed over time. They can be prospective or retrospective. Prospective, for example, would be if we have appendicitis patients that we admit to hospital and we follow them up and see which group develops complications and try and see what is the traits of each group that predisposes them to complications or no complications. Retrospective for a cohort then would be same two groups, but we identify the problem later. So we identify, let's say for the appendicitis patients, they have developed complications, and we now do a review on their notes and see what are the differences between the two. Why did one group develop complications, one didn't? These are usually cohorts on databases, and since we have started a database for our department, that's probably a lot of the research that we are going to do. How do you know what is observational study? Well, sometimes it's pretty obvious. As you can see, enteric duplication in children, a case series, it tells you exactly what it is. Sometimes it's not quite as clear from the heading, and we actually have to read through the methods of what was done in this study on upper GI study on operative management of reflux disease. In the methods aspect, you see it's a retrospective analysis, and it's a retrospective cohort if you read through the full article. That's the easy way to see what is the one, what is the other, and you can start grouping which what article you're reading, which study does it fall under. We'll go, as we go through the talk, I'll explain more why that becomes important. Then we come to experimental studies. Like I said earlier, there's always an intervention involved, and they're usually clinical trials in our settings. There's a few aspects that form part of any experimental study. One is the controls. It's usually two groups, can be multiple groups, but often two groups, one with a new intervention and then one with a sham intervention like a placebo drug, or compared to a normal routine intervention if we compare it with a new antibiotic treatment or something. Then you can have multiple different controls. One would be a self-control, where you use the same group of patients and you review them before and after each intervention. Or you can have a crossover, which is two groups of patients. The one gets the intervention A first, the other one intervention B first, and then you cross them, they do their own self-control, and then you cross them over and do the same study with the other group again. Sometimes we see that if they try and see, well, the study I came across with had anti-cholesterol treatment, and they compared group A, group B. Group A had the old treatment, group B had the new treatment, and then controlled them over a period of time and then crossed them over and did the same study again. It's relatively easy to get more numbers into a study if it's limited in terms of numbers. Then there can be external controls. Often they're historic controls. For example, if we come up with a new treatment that has never existed before, we then just control against what has been there previously on previous records. We can also have uncontrolled experimental studies. However, they're a little bit frowned upon, as you can't rule out bias. And then the gold standard is a double-blinded randomized study. So what does blinding mean? Well, we can blind patients, we can blind their caregivers, or we can blind the observers, or we can blind multiple of those. So does the patient know which treatment are they getting? Do the caregivers know which part are they giving, or do the observers know what's happening? And a double-blinded trial would be that patients and observers are blinded, and only the caregivers are the ones that know which intervention who is getting. This is done to try and minimize bias during the study and get more objective results. And then randomization is required to try and get an equal spread of patients that represent the actual population more accurately. There's different ways to try and randomize and pick patients. I'll go through that in a second. This again is done to try and decrease bias and to get the more accurate result that will then reflect the actual population's parameters. But always keep in mind, if we read any studies, what are the biases? They're often hidden and not completely easily seen when you read it through the first time. But if you read through any study, look what could be potential biases so that you can keep that in mind when you interpret the results. Then meta-analysis is considered the next higher level of evidence. This is done through a very wide and all-inclusive literature research over a specific question that we might want answers for, and then look what other studies have answered and combine that data. This is often done if there's multiple small studies who've been done throughout the world to try and combine their data to try and see if they become statistically significant. They have to be rather specific in their inclusion and exclusion criteria so that we can actually be sure that apples are compared with apples. These are the specific inclusion and exclusion criteria make or break the quality of the paper. And then when we do statistical analysis, we again have to be careful what and how the variables were compared to see whether that is actually a true reflection of what's happening in a population. I've quoted here one article on laparoscopic anterior versus posterior fundoplications for gastroesophageal reflux disease. It's a systematic review and a meta-analysis of randomized trials. But the one big critic to this article is that they didn't differentiate between the different, especially the different posterior fundoplications that are available, and they just grouped it anterior, posterior, and not the various versions that are available. And therefore there might be bias in their conclusion. And that's just to highlight that we have to read these articles with the investigative mind and think about what they have written and how does it include and exclude certain aspects. Then on systematic reviews, they are often considered the highest standard of evidence. It combines qualitative and quantitative research. It is considered the best summary of the topic at that specific point in time. It also includes extensive research through the literature, but it's not just analysis. It also includes a discussion and a recommendation usually at the end of the articles. And it's relatively easy to pick them out. Like this example here is surgical management of Crohn's disease, a state-of-the-art review. Well, it basically says what it is, and we know that this is a systematic review. Then just coming to some more definitions. We have descriptive statistics. They basically just give us a summary of what we've seen in our study. So these includes averages, modes, so what is most often, or number of boys or girls, or number of appendicitis patients that we have seen. But we can't do any real comparison between the parameter or the statistics that we have. So we just describe what we see. In Nauhaus' current MET, that's basically what she's doing. She's describing what she's found. Then we have inferential statistics. They're there to, we have a sample, we analyze it, and we then want to infer and see if that is true for the entire population. Just some definitions to that. A population, whatever aspect we study is called a parameter. in a sample, which is a sample of the population, whatever data we study and then do mathematics on is called a statistic. Keep in mind that the sample, the accuracy is linked to how well it represents the population, which is sometimes quite tricky because often we don't know what is our population's default, and we're trying to study exactly that. Then variable is the group name for any data value that we're looking at. And then a data point is the single value of a variable that we're looking at. Just to understand what is going on, if you read through an article, what does these different things mean when they talk about it? Then coming to some more data types, they're basically categorized in two big groups, categorical and numerical. Categorical, well, the name says it's basically categories. In those two, we have two categorical ones. Nominal ones is basically things that we can't really quantify any other way. It's gender, it's colors, it's diseases. We can count them, we can describe them, but we can't really do any more analysis on them. Then we get ordinal categorical data, which is also still things, but they have some order to it, like pain scores or like a style questionnaires where we are asked to rate something from 1 to 5. These have order, so they can be rated a little bit more than just normal plain nominal categorical data. The numerical data is the one that we can actually do some maths on. They grouped basically in 2, and out of those 2 again. The interval ones are numbers that have meaningful increments of difference, like temperatures, where it's 1 degree and 2 degrees higher, and you can actually say from 1 up to next up is the same degree going up. So they're defined increments as things go up. They're not percentages of each other of 1%, 2% going up. Then ratio numerical data has a true 0, where a baseline can be established between our data value and their absolute 0. This is, for example, age or white cell count. You can't be minus. There is 0 age, there is 0 white cell count. If there's a minus white cell count on a blood result form, I will question what the lab has been doing with the blood. Then 2 other numerical data types are discrete. So one that has definitive minimum size or binominal values, like yes or no. You can make yes a 1 and no a 0 and then count those. Or if you roll a dice, 1, 2, 3, 4, 5, 6 on a dice, those numbers are discrete values. And then continuous is anything that can be subdivided further and further. So if we had better analysis, if we could take a blood pressure more accurately than what we can do in the ward at the moment, you can actually get not just a BP of 120 over 80, but you can get 125 over 82, or you can get 125.3 over 82.3. So those are continuous data types. White cell counts, HBs, are also considered continuous numerical data types, purely because there are so many. It's a white cell count of 10 to the power of 9 that practically you can subdivide them into tiny little pieces. These are important because different data types need different analyses, and we have to have a bit of an understanding of what the differences are, and if you dig deeper into statistics, understand which test you apply to which to give you actually a meaningful answer. And if the wrong test was applied to the wrong data, you can't trust the result. So what happens well, with our descriptive statistics, just a few words on what the different things mean. I take it that most people have at least heard of mean, medians, and mode somewhere along, at least in their school career, hopefully somewhere in undergrad training as well. But they're basically just used to describe statistics. Mean is the average, very easy. Everyone knows how to calculate the average. Median is the middle value of the data that we're looking at. That means you count how many different ones you have, and you take divided by 2, and the middle value of that is the median. So it's not the average, but it's the median value. The mean and median may or may not be the same if you look at it, and it's quite helpful in our own data if we look at the mean and the median. They tell us whether there are outliers, especially if the mean and median have quite a difference in their values. And then we have to look through our data and see what outliers are there, and are they significant, what happened there, and whether or not we include them in our data. And then mode is the one where you count which answer, especially in Likert scores, has been there the most often. Then from there, we actually want to describe it a bit more. So we want to give a range. What is the minimum maximum value? Quartiles and percentiles. Quartiles or percentiles are just more accurate or with finer detail than quartiles. But quartiles, as you can see here on the picture, your median will be your second quartile. And then between all the data that you have, you again count all the different values you have, and you take the middle value between the maximum and the median value, and that will be your third quartile. And then on the bottom, you take the minimum value and count the amount of data you have, data points you have, and halfway between those two is the first quartile. And then standard deviation is the distance between data points and means, and they are worked out, again, relatively complicated, so I haven't included it here, but is to see what would be a normal range and who would fall outside it. We use standard deviation these days to plot the weight and height for our children and see whether or not they fall into a normal range. And if you fall in the third or standard deviation, you know that their weight for height is rather low or high. And this is an outlier of the normal range of data. But there's a lot more to it. I just don't have the time to go through that. Then coming to methods of obtaining data, we often can't use the entire population there is, so we try and get a sample as a representation of that population. The larger the samples, the less likely that or the more likely that they will actually represent the population. But then we have to look for bias in the sampling area. If it was a sampling area, how was the sampling done? In observational studies, as I've said earlier, there's often bias, so we have to look for it. In observational studies, we often look backwards. We have to deal with the data there is, and we can't try and move bias out of it. And when we write up an article, we actually have to mention that and say that in this article, there could be bias for this, this, and that. So how do we sample our population so that we can get a sample that we can work with? So there's simple random selection that requires that you know exactly who all is part of the population, and you pick at random 50 people out of it, for example. But it requires that you need to know everyone. It's relatively simple if you want to do a study on the hospital staff, because HR should have a list of all the people who are employed at Freya, and you take 50 people out of those, and that will be a simple random selection. You can also do a systematic sampling, where again, you need to know exactly who all is the entire population. Again, if we use Freya staff, for example, we would have a master list. We know who's employed at Freya, but we can say, we can go through the list and say we only take every 10th person who's on that list and put them into the group that we're going to study. That's called systematic sampling. Then cluster random sampling is often done if we don't have a master list of who is in the population. So we want to study, let's say, hypertension, or I don't know who, yeah, let's say hypertension, and who comes to clinics. We can pick a few clinics, and then from there, say every 10th patient that we want to see, and ask them some questions. And then stratified random sampling, you have two mutually exclusive groups. So we could say gastroschisis patients, and we stratify them into male and females because gender is mutually exclusive, and then look at the different data points between those groups. Again, what's important for the methods of sampling is, if we read through an article, is to see whether the sample that was taken in someone else's study is representative of our own context. So again, read through that section carefully and keep in mind the population we see. Often if we have a first world study compared to our third world setting, it's very clear that it's not the same population, therefore we cannot necessarily use all their data for us. Then coming to hypothesis testing, which is used in, well, trying to see what is the statistical significance of things. So any study we start, we need to make a statement. Girls do better or have a better outcome with gastroschisis than boys, just as an example for our statement. And we then have to define our null hypothesis and alternate hypothesis. Null hypothesis state that there's no difference between the two groups. We often work out on a p-value, and we'll come back to a p-value in a second. We work out the p-value, and if the p-value in medicine is more than 0.05, we cannot reject our null hypothesis. Therefore, there might not be a difference between the two groups. The alternative hypothesis is that there is a difference, and we reject the null hypothesis and accept our alternative hypothesis if our p-value is less than 0.05. These are worked out in graphs, normal distribution graphs. We work out what is the 5% on one end or the 2.5% on either end, depending on whether we do a one-tailed or two-tailed test. But I'll come back to p-values in the next slide to explain a bit more about it. Again, it's sometimes not mentioned in the studies or articles that we read, but we actually have to figure out what was their null hypothesis, what was their alternate hypothesis, and whether they're supposed to use, or whether they wanted a one-tailed answer or a two-tailed answer. One-tailed would be, for our gastroschisis patients, there is a difference. So it's just, yeah, there is a difference, but it doesn't matter which side it is, whether boys do better or girls do better. That would be a two-tailed test. And if a two-tailed hypothesis, if we say the girls do better than the boys, that would be a one-tailed answer, and the statistical analysis that we do on the data that we have depends on whether our hypothesis, alternate hypothesis, is one-tailed or two-tailed, and we therefore have to pick the correct tests. Then coming to p-value, in every single study that we see, there will be some mention of a p-value. It's actually quite complex to try and understand where it comes from and how does it get calculated. But it is the probability of an event occurring, and it's done through the calculation of a geometrical area. That's why we keep working on these graphs and highlight the one area. It's used to check if the probability to find the same value in both groups is low enough that therefore they are two significantly different groups. We, like I said earlier, in medicine, we kind of decided on 5%. Therefore, a p-value of less than 0.05 is significant. A p-value more than 0.05 means that the likelihood that the two values of the same group is not statistically different. Other parts of studies in the world, or scientists in the world, from biologists or microbiologists, depending on what they're studying, they actually define their p-value differently. And we just have to actually read through what is the p-value and how did they get there. So again, for discrete values where we have 1, 2, 3, 4, no commas whatsoever, it's very, very easy to calculate a p-value. You just draw a graph and you pretty much can read out the p-value of the graph. On continuous data types, it becomes much more complex, and we can actually only work with probabilities of a range of values. There's no specific values. That's why we talk about p-values greater or lesser than a certain value that we pick. And then we work out through complex calculations how to give, what is the p-value for our data, and then compare where does it fit. So just to illustrate it a bit graphically, we have a normal distribution graph. We decide that our 95 statistical significance threshold, it's 95%. We draw the line there, and then we check where does our observed result fall. If it falls to the lower end of the graph, on the tail end, that's not supposed to happen. On the tail end of the graph, we know that it's statistically significant, or at least we hope so. If it falls into under the big area of the graph, we assume that there's no significant statistical difference. However, the 5% is a value that in most medicine we have agreed on. It doesn't necessarily mean that there is 100% statistical significance, but if we make it less than 95%, especially in medicine, we find that a lot of our studies end up being non-statistically significant, and therefore we have settled on a 95% statistical significance. Then just to highlight some of the types of tests that can be done to work out p-values. They roughly get grouped into numerical testing and categorical testing, depending on the data you have, and then parametric, metric, and non-parametric tests. To go through each one of them is too complex and is going to take us weeks to get everyone to understand what they're all about. But I just wanted to highlight some common ones, names that you'll come across if you read studies, and ideally should try and read up around it to see what do they mean and where do they come from. So under parametric testing, we have students' t-test. You see it in quite a lot of studies. The ANOVA one compares more than 3 groups, but then you have to do further individual testing between the groups to get actual p-values. Linear regression, and then under the non-parametric tests, we have also a whole bunch of them that kind of correlate to a lot of the parametric tests. The Mann-Whitney-U test comes under multiple different names, but Mann-Whitney-U is the most common one used, and it's quite a commonly used test that I've come across in a whole bunch of studies, the same as Kruskal-Wallis, and then the Wilcoxon and Spearman rank, I haven't seen that frequently. And then categorical testing has a Charcot square test and a Fisher's exact test. Those are fairly common ones that we come across. Unfortunately, it will really take a lot of time to try and explain where do they come from, how do they get to there. So I just settled on mentioning them, that you know that they exist, but it takes a lot more time to understand them.
Helga, are you coming to the end of your talk now? Sorry.
Almost.
Okay.
Then as last one, confidence intervals that we come across also relatively often. Again, it works with a bell-shaped curve. It's the assurance that the population parameter falls closer to the study's mean. And we again use customary in medicine, a 95% confidence interval. It is not the percentage or the probability that it will fall under, but it means if I repeat a study 100 times, 95 times the mean of the actual population will lie within the set limits for whatever data we're working with. And the graph here is just to illustrate how that kind of works. If we pick 68, we have a lot of data that falls out of it. 95%, we already include a lot of it. But to have a 99.7 confidence interval is very difficult for in medicine. Therefore, we settle for 95 confidence intervals. So in conclusion, statistics is a whole degree on its own, and there's a lot more to understanding statistics than what I can share in 20 minutes, half an hour. We need to understand statistics to be able to read more than just the introduction and the summary of any article, and actually understand a bit more what is going on in the article so that we can compare it to our setting and see whether it's useful to us or not. Also, if we write our MATs, we need to understand a lot more about the language used to be able to do a proper literature review and to be able to do our own MAT. And it's important to read critically through studies and understand what they are talking about and what their limits are, so that we can actually make them work for us or reject them if it doesn't work for us. Thank you.
Thank you, Helga. It was a nice presentation. Prof. Sheikh could join about 10 minutes late, but he has joined. So I will invite him to comment now. And I would like him to actually tell us what is the significance of all this knowledge in our actual pediatric surgical practice, and how do we incorporate this knowledge while we are studying or practicing and while we are conducting any research. Samad?
Thank you, Milind. Yeah, sorry, I got stuck in theater, so I missed the first bit of the talk, but I will try and sort of just fill in the bits and pieces that I think will help answer the question you've just asked. Overall, your registrar's given a fairly good cover, but the way I look at statistics when it comes to a daily application or an application of it in terms of my regular practice, I look at statistics as falling into two separate areas. The one area is, how do statistics apply to a research project that I am interested in conducting, or how can I apply research to answer a question that I have? And then the second aspect of statistics is, how does it help me interpret the data that is presented in a particular paper, or how the paper is actually reviewed? So just very quickly, if we look at a research project that we would have, it would be a question that I would want to ask as to how many of my children with necrotizing enterocolitis survive, as a simple example. So I would look at that, very quickly define a population. It's all my patients who present with necrotizing enterocolitis. It's fairly easy. And I would ask my question, which would be my hypothesis. And my hypothesis would be that 20% of children with necrotizing enterocolitis survive. Once I do that, then I know I'm going to have to collect the data, and my data will fall into two categories. It will either fall into numerical type of data or the so-called categorical type of data that was discussed earlier. Once you know what type of data you have, it's very easy then to apply the statistical test that you will use to reach a conclusion that will either prove or disprove your hypothesis. So if we have categorical data, it's very simple. Are there 2 or 3 paired groups, and you know which test to use. If you have numerical data, then you've got to decide, is that data likely to be normally distributed or not, which is the bell-shaped curve that was spoken about. If the data is going to be normally distributed, which means I have a large population, and that's not going to apply to my study because my study is most likely going to be non-parametric. It's my very own patients. It's from a select group. It's a small number of patients. So the actual data is not going to be representative of the general population of follow-up bell curve. So that will be non-parametric data. So if you have the parametric data, which is from a large population, all the medical schools in the country and all the NEC, then we will apply very specific tests. Those are the paired t-test, unpaired t-test. And if it is non-parametric, we know which test to apply. So actually doing it from a paper point of view or a research question point of view, it is relatively simple if you break down your research project into a simple question with a straightforward hypothesis or 2 or 3 questions which need to be answered, and then identifying the data that you will collect and the type of data you collect. So statistics from that point of view, as applies to a research project, is fairly straightforward on my side. In terms of interpreting statistics from a paper, that's a little bit more of an issue, and that would probably apply more to the question that you're asking as to how does it apply to daily pediatric surgery. And to answer that question, I think it's more important that you are able to interpret the terminology that is used. So simple things like what are the differences between mean and medians are fairly easy. But sometimes terms like standard deviations or standard error of the means, or how a relative risk, what does a relative risk mean? What do the odds ratio mean? I think those are important aspects to understand when it comes to into your daily sort of practice. So if you read an article on gastrosthesis and you want to try and see if that data is relevant or not and how it applies, then you would have to understand these terms. I think COVID has been very, very useful in this particular scenario because you will look at the number of papers which have been retracted from very large journals, from journals, which have a large readership like the Lancet. And these are articles that were published there rather rapidly and found to have weaknesses in the statistics and the way they were reported. So it's always important to have some sort of an idea as to what the terms mean and how you can actually interpret them. So, I mean, simple things like the standard deviation, we know will refer to where you have a continuous sort of a numerical variable, which will cover data of a continuous type. And all it does is it measures how variable your actual data is. So, or what the scatter is. Are all the data focused around one point, or is there lots of scatter? So you're getting figures from 0 to 100 rather than all around 50. Similarly, for things like the risk ratio, I think that's something important that people have to understand. I'm not sure whether it was already mentioned, but when it comes to interpreting percentages where the answers are sort of yes and no, it becomes a little bit more difficult. So that's when risk ratios or odds ratios become applicable. And a really useful term is the number needed to treat, because for our type of practice, where we look at a particular sort of intervention, let's say octreotide for chylothorax, for example, knowing what the odds ratios are or what the relative risk is of the patient getting better doesn't really mean too much to us. But if we are told that you need to treat 150 patients with high dose somatostatin or sandostatin in order to relieve one patient with a chylothorax, it tends to make more practical sense in terms of how we work. So the odds ratios, relative risk, those are the ways the data are now reported when it comes to the type of practice we see. P values and things tend to be more important when you have continuous variables, but we should actually probably pay more attention to relative risk and odds ratios, because our patients often have, or we are usually looking for a simple yes or no answer in terms of an intervention that we are doing, rather than how likely they are to benefit from a particular intervention. I think the other important factors are the type 1 and type 2 errors. If that's sort of discussed, then that would be an important aspect to understand what the difference between the two types of errors are. And interpreting a p-value, I think, is very important. So whenever you have a p-value, it may, for example, carry a lot of weight in a randomized control trial, but it is not necessarily significant in a question that we would ask from a case control type of study that we often do. So the p-value really only plays a role in trying to disprove the null hypothesis. And very few of the studies that we get in pediatric surgery actually follow the idea or follow the principle of disproving a null hypothesis, although p-values are widely reported. Its specific use is supposed to be in disproving the null hypothesis that you actually propose. So I think that's an important aspect. If we can look at a sort of simple example as the preoperative radiotherapy or chemotherapy versus surgery, as compared to surgery alone for a tumor, for example, you have to look at the overall survival as your endpoint. But what you've got to then focus on is proving that your overall survival is not likely to be what you expect. So that's the null hypothesis. And I'm not going to go into detail about it unless you really want me to, but it's important to understand what a statistically significant result is in terms of a p-value as compared to a clinically significant result. So the p-value is just telling you that the chances of the null hypothesis being correct is more or less than 5% in terms of the value that we have used, but the clinical significance of that result is not contained in that particular number. Your odds ratio, your relative risk tend to give you a better idea of, or the number needed to treat, a better idea of what the clinical significance of a result is going to be as compared to the p-value. Just, I think, a last point without having to go into anything else is just to come to review this whole evidence-based medicine concept and this pyramid of evidence-based medicine concept, which is right at the bottom. You have your own experience versus right on the top, the so-called meta-analysis, systematic reviews, and the rest of it. What we've got to understand is that based on that type of evidence-based medicine, a huge focus is placed on the randomized control trials and evidence that is derived from that. But the randomized control trial does not reflect real-world experience. And real-world experience is a concept which was introduced a long time ago, but has recently become far more important in terms of applicability. And to a large extent, the courts of law now find real-world experience to have the same level of sort of legal significance as does evidence-based medicine. And real-world experience, very simply put, refers to the data that is collected from the type of trials that we often do. So we go and pull out a whole lot of files from a patient in the clinic, from patients in the clinic with gastroschisis, for example. We review that data, and then we publish the statistics based around that data. Those statistics, because they are case controlled or retrospective, tend to have a low degree of significance on this pyramid of evidence-based medicine, but actually are far more applicable clinically to our patients than a randomized controlled trial on the management of gastroschisis, which pre-selects the group of patients which are going to be analyzed. So a randomized controlled trial is not looking at the real world patient it presents to you, but it pre-selects the patients that we have a particular interest in. So I think real world experience is something that you have to know a little bit about, and you have to understand that it can sometimes be considered at the same level of evidence as randomized controlled trials are considered, especially in a surgical discipline where our surgical experience is often derived from experience. I think that should cover most of the comments. Melinda, I'm happy to answer anything specific, but just from a topic point of view, I think we have to apply what we can to our practice and interpret it from a relatively simplistic point of view than trying to understand why a Mann-Whitney test, U-test is used rather than an analysis of variance or an ANOVA, for example.
You know, Samad, that is perfect. I think what you have given is a very important advice for two.
Sorry, Melinda.
No. I think your advice has been perfect. I don't think we need anything more at this stage, because you have actually given clear-cut guidelines to the registrars when they select their thesis topic to keep it simple, to have only one or maximum 2 or 3 questions, and that way it will be much easier to do the mini dissertation. That's number one. And secondly, you have also brought out this very important concept of real world experience, which is what is more clinically important for us in our day-to-day practice. So thank you for that. I think I'll invite Professor Hadley, who also has huge amount of research experience, to give his comments. Prof, we know this is a very huge topic. So just whatever you would like to advise us. Thank you, Prof.
Good afternoon, everybody. I'm pleased to see that this topic has come up for discussion. I don't want to go into statistical tests, largely because I don't understand them. But what I would like to emphasize is that as practicing pediatric surgeons, we have responsibilities. And our first responsibility is to apply known science to our patient care. And that means that we've got to be able to read the literature sensibly. We've got to be able to interpret the literature, and we've got to be able to apply what we've learned from the literature to our practice. And secondly, we also have a responsibility to do research ourselves. And it's, I mean, to me, it would be terribly unfulfilling if as a practicing pediatric surgeon, you ended up at the end of your career doing exactly what your boss told you to do at the start of your career, to manage patients. And so nothing has changed and nothing has been learned. So at this most basic level, we've simply got to record what we do and see if it works. And then if we find that it doesn't, we can try something else. So to start the research tradition at a school, I think it's important to start off with observational research and just pick basically your whole practice and look at it and see what's going on there. And then make your conclusions from your own experience. And then we need to compare it to people who have populations like us. There is absolutely no merit in comparing a series of gastroschisis patients, gastroschisis management in East London with what they are achieving in Boston Children's Hospital. That to me is unrewarding, unfulfilling, and very often just depressing. What we should be doing is we should be looking at East London and saying, how are we doing relative to Cape Town or Harare or Nairobi? And making sure that we are comparing apples with apples, because then the research bug catches on. In surgery, we can't do sham operations, so there aren't going to be many randomized, prospective, double-blind controlled trials. The surgeon always knows what he's done, at least I hope he does. So we are stymied from that regard. And there was a very important paper I thought that perhaps you should look out. It was by our colleague, David Muckett, who you will know, Millen, who said, evidence-based medicine, are we boiling the frog? Because when you think about it, these meta-analyses are all based on randomized controlled clinical trials, all of which are of different quality. some of which are very strictly managed and others are not. So you can end up making a decision on the meta-analysis of bad data and calling that evidence. So I think Professor Sheikh's point about real-world experience is vital in the sphere of surgery in general and pediatric surgery in particular. With that, I'm going to shut up. Thank you for the opportunity.
Thank you, Prof. Thank you very much. Now I'll invite Dr. Yashoda Manikchand, who is our consultant pediatric surgeon and who is quite keenly interested in research. And actually, she has been instrumental in starting an electronic entry of our operation notes and a new electronic database for our patients. So Yashoda, please, your comments.
Hi, everyone. Yes, thanks, Prof. Thanks to Helga for that very difficult topic to cover. And she did well, I think, to explain as much as she could in the time given. And I think Prof. Sheikh and Prof. Hadley have just summarized everything pertinent to the pediatric surgeon. So a lot of just two very quick points that I'll kind of summarize basically what they said, I think. Is that we are informed by the research. So it's very important, valuable to create research that we can all look at and be informed by them in order to make decisions about our patients. And I think they both kind of made that point very well. And then also that we have a paucity of data from the developing world. And we're looking at developed world research and we're trying to fit it into our environment, which is not very helpful for our patients. So we need to keep that in mind and we need to add to that database of the developing world. Thank you.
Thank you, Yashoda. That's very important comments you have made. And I think previously, we did a lot of work. I mean, we treated a lot of patients, but our record keeping was poor. We couldn't access the files. And that was an important reason why we could not collect authentic data. But I think with our electronic record, we are far better off than what we were before. So thank you for that. I'll invite now Dr. Selo Machaya, who is our other consultant, also quite keen in research. In fact, he has recently enrolled for a PhD. So he is the right person to give his opinion and comments. Selo?
Thanks, Prof. I don't think I'm the right person yet. But yeah, I think what someone told me once that when you're actually reading a textbook, it's like basically looking back in time. So as much as a textbook is relevant for what you're doing, it was ultimately printed now, and the work that was actually done in that textbook was 5, if not even 10 years old. So that's why it's important, I think, to have continuous updates of what's happening. Hence why like journal clubs are very pertinent and important, because other than teaching you or giving you exposure to what's recent about that specific topic, they also help you critique an article and help you kind of start dwelling or kind of looking into the research world and the research language, because unfortunately research is like a French woman or a French man. From afar they look pleasant, but once you come to them close and try to communicate to them and you have no idea how to speak French, it becomes difficult. Then it's not something that's so attractive anymore. So once you know the language, then you're able to communicate better and be able to actually enjoy research. I kind of personally did not like research much, but I'm starting to get the hang of it because I am slowly learning French. And it's a very interesting language to learn. Thanks, Prof.
Thank you, Selo. That was very nice simile. Thank you very much. I don't see Dr. Majola. So I think we are coming to the end of the topic. I think I'll just invite Prof. Sheikh just to give a final comment before we close. Samad?
Thanks, Milind. I think it's having these kind of discussions very important, because hopefully it will get people interested in research and doing this kind of stuff. But I think the most important thing is you don't have to spend way too much of time learning about statistics, because you have people who can do this for you. So Prof. Hadley would say, since he's here, I'd mention it, is that why bark if you can get a dog to bark for you? So the idea is to get the right question, collect the data, and you do have people who know statistics really well to help guide you with the tests and the rest of it. Just understand how the test is applied to your clinical practice. Knowing the theory behind the test and things is something that you will have somebody way more experience than we are to help with. Thanks, Milind.
Thank you, Samat. I think, again, very wise words. And same advice to the registrars: keep your mini dissertation topic simple, and it will consume less energy, less time. It will be interesting for everybody to read it, and it will save you a lot of time and energy. So thank you very much. That was quite an important, uninteresting topic, but very nicely covered by Helga, and we got nice advice. Next week, it will be only M&M meeting, only restricted to the staff of our department. But in 2 weeks' time, we will have a talk about nuclear medicine in pediatric surgery. Dr. Kerat Botha, our medical officer, will give this talk. And we will have Dr. Anita Brink, who is a nuclear medicine physicist at Red Cross Children's Hospital. She will be the invited guest, and we may have one more nuclear physicist who could also attend. So we will see the rest of you in 2 weeks' time. Have a good evening. Bye-bye.